Hi, this is Andrea again, and I am here to talk about Chapter 12, which is ICD-10-CM coding. This is for HIT 210, and this is part 2, and we're heading into talking about index and tabular. So if you left off with part 1, this is the next set that we'll do. I have pulled up the CDC's website here. You can look at the top of my screen and see icd10cmtool.cdc.gov. Now you'll notice right here on the screen where I'm circling with my cursor, it says fiscal year 2019. We are now in fiscal year 2020. So if you click on that and choose fiscal year 2020, you have the most up-to-date codes. If by chance you were looking for a code from fiscal year 2018, you go back down here, or fiscal year 2019 and change it back. But we are in fiscal year 2020. The government's fiscal years start October 1st and run through September 30th. So October 1st of 2019 began fiscal year 2020. And October 1st of 2020 will begin fiscal year 2021. Crazy, I know, but it is one of those things that we just have to be aware of to make sure that we're using the correct information to get where we need to go. You will see here indexed diseases and injuries, external causes of injuries, table of drugs and chemicals, and table of neoplasms. Now I talked about these last 3 tables recently and said that if that's where you need to go, that's where you need to go. You won't go into the index. You'll go to one of those tables and find what you need. If it's not an external cause, it's not a drug or chemical issue, and it doesn't have to do with neoplasms, then you're going to use your regular index. And then from the index, once we get to the index, then we will head into the tabular. So let me give you an example of this. Let's say that you are looking at a situation of something you might get in the office. Oh, let's see. How about with this time frame and everything going on, let's say someone has an earache, and you're eventually going to run some tests and figure out they have acute otitis media with perforated left eardrum. Okay, so acute otitis media with perforated left eardrum. That's what we're going to code. So you're going to type in here otitis media. Let's try that and see what we get, if I can spell it correctly. There we go. Okay, otitis media. If you look down here, this is blue. You now know we're in the index to diseases and injuries, and it also says that right underneath. Okay, we looked up otitis media. What do we know about this otitis media? It's acute. That's all we know. Acute otitis media. We also know we have a perforated left eardrum. Is there anything in here about perforated eardrum? No. Not seeing anything in there. Oh, yes, we are. See, look, if you come over here, rupture of eardrum. With rupture of eardrum, that's what a perforation is. So you've got the H66.9, but you also have this rupture of eardrum, which is going to take you to H6601. Now, we're not sure if that's going to be our final code or not, remember, because we're still in the index. What we're going to do is we're going to click on that code, and we're going to suddenly be going into the tabular, okay? This is where we talked about the index versus the tabular. Over here on the legend, there are different types of notes. And as you can see below, once we start really getting into this, we'll go through each of these notes and see what they say, what they mean, and how they influence what we finally do code. So If it's an I here, it means there's notes to go with it. There's something additional you might need to read. If there's a paperclip here, it means includes. So that means it's got to have both pieces for you to code it. It includes. It's more than one thing, which, as you can see on the screen, it's acute otitis media with rupture of eardrum. And again, we were looking at acute otitis media with perforated left eardrum. And you can see if you go down a little bit further, oh, look, there's a left ear there. If we would have just coded this off the index, would that have been correct? No, because we didn't clarify that it was the left eardrum. And that's what we're looking for. Okay, so that includes, that helps you remember, oh, yeah, I have to have both things documented in order for me to use this code. The next one is use an additional code. Here, they're saying you may have to use an additional code. One code may not be enough. You're coding the underlying problem, but are you coding the manifestation? So remember, here at the top, we're looking at the legend. When you have those two green flags, it means use an additional code if that's the way you're directed. If you run across the two flags with a 1 on it, means something has to be coded first. And this will tell you which one has to be coded first. So be aware that sometimes, yes, you have to have two codes. You have to have an additional code, but you also need to know which one gets coded before the other one. And this will give you notes on that. Whoops, come back here. There we go. Code also. Sometimes it'll tell you that you need to have two codes so you can code everything. And this will tell you code also. And then this one tells you, oh, you're going to have to use a 7th character. And odds are that 6th spot may need an X placeholder there. So this is just a warning about that. Now, an exclude 1 note means you can't code that here. If something comes up under an excludes 1 note, it means you cannot code that here. You have to do something else. A good example that they give you right on the screen is that if you have a congenital form of something, meaning you were born with it, you can't also code that you acquired it during your life. They're two totally opposite things. Either you had it at birth or you acquired it later in life. And you can't code both. So when you see that one with the red drawn through it saying excludes 1s means you can't code it here. Excludes 2 means it's not included, so you're probably going to have to, it means it's not always included here. The person could have both conditions at the same time. And excludes 1, again, means you absolutely can't have both. And excludes 2 means it's usually already included or through a different code. Odds are you're not going to have the same thing at the same time, but you could. And if you do, you can use them together. So in the uncommon situation that you do have something and it's not normally with what you're coding, and it's under an excludes 2 note, if the patient truly does have both conditions at the same time, you can code it. So you want to make sure you understand the difference between an excludes 1 and an excludes 2. Excludes 1 means never code together. Ever, 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 never, never, never. And an excludes note means it's going to be really rare that these things occur together, but it is possible from a medical standpoint or a surgical standpoint. And so therefore, in the rare occasions when it does occur, you can code both. So that's what those mean. So let's go down again. We're here at H6601. You see where my cursor is? Acute suppurative otitis media with spontaneous rupture of an eardrum. And what we're trying to code is acute otitis media with perforated left eardrum. Ooh, left eardrum. Interesting. So we're going to go down here and we're going to see that we have it. And it's the left ear. Okay, so we're now down to H66012, reflecting that it's that left ear. So let's go over and see what it says. Information. They want you to use an external cause code if one is known or applicable to identify the cause of the ear condition. In this case, there's probably not, unless you have some type of bacterial infection or something else going on like that you can code. Maybe the doctor is able to identify the virus behind this or the bacteria behind this, if for instance it was cultured or that sort of thing. Then you would want to code also the infection. But otherwise, an acute earache is not really something that you're going to have an external code cause for, unless you're talking about maybe does the child have secondhand smoke situation at home or that sort of thing. Okay, so the next one includes. So if you also have myringitis, whoops, let me go back here. Myringitis, if you always also have that, it's included in this code. You don't have to code myringitis separately. That's what it's saying here, is that it's included. Okay, so now we've got this, and it's saying use an additional code. What is that additional code? It is, if you know this, if it's documented, because again, you have to go back to your documentation, that maybe they were exposed to environmental tobacco smoke, that's that secondhand smoking, or maybe they're a former smoker or a current smoker, you should be using one of these Z codes to reflect that. But that's only if it's documented. If not, then you don't use it. Then you have an excludes to note. So that basically all these other things are not going to be included when you code. You're not going to code them also, because they rarely, if ever, happen at the same time as acute otitis media with perforated left eardrum. Okay? So, what is our final code? It is H66012. That is our final code. All right? And that's how we did it, using the index and then the tabular. So let's go back to our slide presentation here. Whoops, wrong one. Hang on. There it is. That's the one I want. Okay, so we're back here. We're talking about the tabular. So we just went to the index. We looked up otitis media because it wasn't one of the tables. And we found under subterm where there was perforated eardrum. And we went to the tabular. We went through the tabular. We talked about whether or not we were using the number of codes we were supposed to. We looked at includes, excludes, instructional notes, those types of things. We didn't have to worry about placeholders or seventh digits or punctuation symbols or not elsewhere classified, not otherwise specified. But we did need to make sure we addressed the acuteness and the laterality, the fact that it was the left. And so we coded from the tabular. So that is how this is done. All right, so this leads us to coding ethically. The codes must reflect the documentation in the legal medical record at the time of coding. I'm going to say that again. Codes must reflect the documentation in the legal medical record at the time of coding. So who can document? You're only going to code information from those who are authorized to document codable information in the medical record. So what does that mean? Can you just code anybody that documents? What happens if you have a housekeeper who documents in the medical record? What happens if you have a receptionist document in the medical record? Can you code that stuff? No, they're not authorized to document codable information in the medical record. Those are your providers, your physicians, your mid-levels, sometimes dietitians, sometimes therapists, those types of things. And you're going to document diagnoses. And there are some times where you're allowed to do BMI and pressure ulcer information from non-physicians like nurses. A wound care nurse, for example, is a really good one that you can pick up information about with all of this. Now, I happened to look down to see the time, and we are just over 15 minutes. Sorry about that. I would like to continue with this slide, and then when we finish with this slide, I'll go ahead and stop the video, and then we'll move on to part 3. So hang in there. When is it documented? You're only going to code if it's in that specific episode of care, visit, hospitalization. You're not going to go back in the record to 3 weeks ago. You're only coding what is in that specific episode of care. So let's say, for example, a patient was in the ED yesterday and they're in your office today. Are you going to code what was in that ED visit from yesterday? No, only what's documented in your specific episode of care in the office today. What happens when there's late entries? We all know that sometimes providers think, oh, rats, I meant to include that and I didn't. I need to go back and do that. And they do a late entry. You can go back and code and pick up the information in the late entry, but you need to make it clear that that's where you were getting it. Hopefully that late entry was made before you coded the first time, but if not, you'll need to kind of make a note in the chart that you added that based on the late entry, and that's where that came from. So then what is documented? Okay, you can't just code anything. You have to code to the specificity you are given. So if the doctor doesn't tell you whether it was left ear or right ear that you had otitis media to code, you may need to ask. It's called querying the doctor. It's asking them, can you give me more information about this patient's condition? Is it left, right, bilateral? Is it acute, and chronic, or acute superimposed on chronic? You can ask them for more specificity. But whatever specificity you have in the legal medical record at the time of coding is what you code. So if they don't give you anything more, then you're going to have to use some of those unspecified codes that not elsewhere classifiable or not otherwise specified. You code for medical necessity and appropriateness. So the more information you have, the better off you are, but you definitely want to make sure that if a procedure was done, that you're getting information to code for that to explain why it was medically necessary and why it was appropriate. So example, if you have high blood pressure versus chronic hypertensive heart disease, what do? Well, high blood pressure is a symptom. Chronic hypertensive heart disease is a diagnosis. And if you're not getting what you need to be able to do this, to be able to gain the specificity you need, that's when you query the provider. That's when you ask them open-ended questions. Can you please, you've documented high blood pressure, and patient seems to have a history of chronic hypertensive heart disease. Could you please clarify if there's a relationship between these, no relationship between these, or what should be the patient's final diagnosis for this visit? And let the doctor answer that. Now, where is it documented? You can't code off Post-it notes. You can't code off verbally relayed information. You can't code from emails, and you can't code from a test result. Just because you get a positive test result in doesn't mean you can code that. It has to be documented in the legal medical record by a authorized provider or authorized person who can document it, that you can code it. So be really careful about that, because Post-it notes get lost or removed. Verbally relayed information may not get documented, and if it does, it may be late, or it may be different when it finally gets written down. If it's from an email, how do you know that it really was the provider that was emailing and not someone else using his email that was up, or those types of things? Emails are not considered part of the legal medical record. And just because you get a positive test result in or a negative test result in doesn't mean that you can code it. You've got to have that interpretation from the provider to be able to do that. And then how is it documented? If you can't read it, if it's illegible, you shouldn't be coding it because you're not sure about it. It's got to be legible and clear in meaning. Providers like to come up with new abbreviations all the time, and that's great, but if it's not clear in meaning to someone who would come in and review the chart, meaning Joint Commission or the state, or somebody from the state medical board, if they can't pick it up and read it and understand what that abbreviation means, it's not appropriate. It's not properly legibly documented and needs to be clarified. The other thing is, did it happen only once and was never treated or collaborated? If it was documented in the chart only once and never treated or corroborated, in that it's verified. I guess verified is probably a better word than that. If it's never treated or verified or followed up on or provided any service for or evaluated any further, don't code it. That's just not a good idea, because you have to, again, go back to medical necessity and appropriateness. If you can't show that you have done something concrete, quantifiable to provide care, treatment services, evaluation, management, all that for the patient, for that sign, symptom, test result, or diagnosis, it should not be coded. It's not appropriate there. So this is a good place to stop. We're just under 22 minutes, or right at 22 minutes, I should say. So I'm going to stop here and end part 2, and I'll be back with part 3 shortly.